Good morning. I am Dr. Neelam Bagwale, Assistant Professor in Obs and Gynae Department at Index Medical College. So today's topic is benign neoplasm of the ovary. So benign lesions of the ovary are divided into non-neoplastic and neoplastic. Non-neoplastic can be functional like follicular cyst, corpus luteal cyst, theca lutein cyst, granulosa lutein cyst, and pathological can be polycystic ovarian syndrome, endometrioma, and tubo-ovarian mass. And neoplastic lesions can be surface epithelium, serous, mucinous endometrioid, Brenner's, and germ cell tumor, that is benign, sex cord or stromal tumor, thecoma, fibroma, or androblastoma. So the causes of non-neoplastic cyst of the ovary are follicular cyst, corpus luteum cyst, theca lutein and granulosa lutein cyst, polycystic ovarian syndrome, endometrial cyst, chocolate cyst. Except the last one, all are functional cysts of the ovary and are loosely called cystic ovary. Clinical features of a functional cyst are: it is related to temporary hormonal disorders, rarely becomes complicated, sometimes confused with neoplastic cyst, but can be distinguished by the following features. Usually it is less than or equal to 7 centimeters in diameter, usually asymptomatic. Spontaneous regression occurs following correction of temporary hormonal dysfunction, unilocular on ultrasound, usually contains clear fluid. Lining epithelium correspond to the functional epithelium of the unit from which it arises. Okay. So the follicular cysts are the commonest. It usually occurs in the age group of adolescent. Reproductive age group can occur in perimenopause. The causes can be hypoestrogenism. The size can grow up from 3 to 8 centimeters. It can be unilateral or bilateral. On gross appearance, it is thin-walled, unilocular, filled with straw-colored fluid. On histology, the lining epithelium, granulosa cells. Clinical features, usually asymptomatic. Diagnosis is incidental. The corpus luteum cyst occurs in the age group of reproductive patients. The causes are overactivity of the corpus luteum. The size can be up from 3 to 10 centimeters. It is usually unilateral. On gross appearance, it is pink or hemorrhagic cyst. Cut section shows yellowish orange filled with blood clots. The histology shows luteinized granulosa cells. Clinical features are dull with unilateral pelvic pain. Rupture with hemoperitoneum are more common. Now, the theca luteal cysts are also very common in reproductive age group. The causes are excess chorionic gonadotropin secreted in gestational trophoblastic diseases following ovulation induction drugs. The size, it can be up to 30 centimeters. It is usually bilateral. On gross appearance, multicystic grayish blue color filled with straw colored fluid or blood. On histology, the theca lutein cells, granulosa lutein cells. On clinical features, they are small, asymptomatic, large. If it is large, then there is discomfort, pain due to rupture or torsion. That is very common. So this is the diagram showing enlarged uterus in the center and bilateral theca lutein cyst. The cyst on the left shows a breach in the capsule and the right cyst with thin hemorrhagic area suggestive of impending rupture. So the benign ovarian neoplasm epidemiology are Its incidence is 1 to 3% among outpatients, 75% are benign. Racial factors, higher in white population, lowest in Japan. Economical status are higher in industrialized countries, and some other environmental factors are also responsible for it. On pathological examination, the origin is mesoepithelial cells on ovarian surface. The incidence is epithelial tumor around 80% of all ovarian tumors. Serous cyst adenoma is 50% of all epithelial tumors. Mucinous cysts are 12 to 15%. Endometrioid are 10%. Unspecified are 25 to 27%. So, the classification of ovarian tumor according to WHO, epithelial tumors are 60 to 70%. These tumors may be benign, borderline, malignant, or malignant. So, it is divided into serous tumor, mucinous cyst adenoma, endometrioid tumors, mesonephroid or clear cell tumor, transitional cell or Brenner's tumor, squamous cell tumor, mixed epithelial tumor, undifferentiated carcinomas. So, germ cell tumor of the ovary accounts for 20 to 25% of all primary ovarian neoplasm. Germ cell tumors are also divided into many categories, that is dysgerminoma, endodermal sinus tumor, that is yolk sac tumor, embryonal cell carcinoma, polyembryoma, choriocarcinoma, teratoma, that is immature, mature, that is dermoid cyst, and monodermal struma ovary or carcinoid, and mixed forms like combination from A to F. C is sex cord stromal tumors that accounts for 6 to 10%. Granulosa cell tumors, tumors of the thecoma fibroma group. Thecoma fibroma unclassified. Androblastoma are Sertoli cell tumor, Sertoli lytic cell tumor, Hylas cell tumor. The lipid cell tumor account for less than 0.1%, and E is tumors composed of germ cells and sex cord stromal derivatives that accounts for less than 0.1%. These are divided into gonadoblastoma, mixed germ cell, sex cord stromal tumor, and others. F is unclassified tumors. These are the tumors that cannot be placed in any of the categories as mentioned above. Soft tissue tumors are not specific to ovary, such as hemangioma or lipoma. G is secondary metastasis, and H is tumor-like conditions, include the conditions that are associated with ovarian enlargement. These are massive ovarian edema, pregnancy luteoma, luteal cyst, endometriomas. These are not true neoplasm. So the benign ovarian tumors can be divided generally by cell type of origin into 3 types: epithelial, stromal, or germ cell. So the benign ovarian tumors are mucinous cyst adenoma, serous cyst adenoma, Brenner's, and benign cystic teratoma. So the mucinous cyst adenoma, the incidence is around 12 to 15% of epithelial tumors and 20 to 25% of all ovarian tumors. It is bilateral in 10% of cases. Malignant chances are also 5 to 10%. The origin is usually from totipotent surface epithelium of the ovary. On pathology, the naked eye appearance shows huge, large, and weight around 5 to 10 kgs, pedunculated, largest, smooth, lobulated, with whitish or bluish white, translucent tumor. The on cut section shows thick, viscid mucin glycoprotein, colorless, multiloculated with papillary honeycombed appearance. On microscopic examination, it is lined by one layer of tall columnar epithelium with dark staining basal nuclei without any cilia. Epithelium resemble to those of endocervix. Complications, there can be rupture, pseudomyxoma peritoni shows adhesions with vice versa. This is a diagram of mucinous cyst adenoma. Now, serous cyst adenoma, the incidence is around 50% of all epithelial tumors and 40% of all ovarian tumors. It is bilateral in 40% of cases. The chances of malignancy is also very high. And the origin is from totipotent surface epithelium of the ovary. On naked eye appearance, it is a smooth, shiny, grayish-white, exuberant papillary projections. On cut section, it is multilobulated, clear fluid serum, proteins, albumin, and globulin. On microscopic examination, it is lined by cubical epithelium, papillary structures, dense fibrous stroma covered by single or multiple layer of columnar epithelium, ciliated secretory and peg cells. Epithelium resemble to those of endosalpingeal epithelium. Brenner's tumor, the incidence is 2 to 3% of all epithelial tumors and 1 to 2% of all ovarian tumors. It is bilateral in 8 to 10% of cases, and the malignant chances is also very rare. Now, benign cystic teratoma, the incidence is 95% of germ cell tumor and 15 to 20% of all ovarian tumors. It is bilateral in 15 to 20% of cases. The malignant chance is also 1 to 2% and 20 to 40% of all ovarian tumors in pregnancy. The origin is the dermoid cyst. Origin are the germ cell arrested after first meiotic division. On naked eye appearance, it is moderate size, capsule is dense and smooth. And on cut section, trabeculated appearance, sebaceous material with hair, clear rocky tensky protuberance. On microscopic examination shows stratified squamous epithelium, granulation tissue may be transitional or columnar. So this is a diagram of serous cyst adenoma and serous and mucinous cyst adenoma. The gross appearance of the mucinous, that is A, and serous B, cyst adenoma of the ovary. The mucinous type is generally multiloculated and can be quite large. This is the diagram of Samoma bodies in serous cyst adenoma in 15% of cases. Brenner's tumor is usually unilateral, small to moderate in size, seen usually after 50 years of age, and on gross appearance resembles fibroma, smooth solid tumor. Cut section shows gritty and yellow gray in appearance. On histology, there is fibrous tissue with transitional epithelium, vaulted cell nest like appearance. On clinical features, there is, on cut section, it shows pseudo-mealy appearance. Endometrioid tumor, it is account for 2% of all ovarian tumors and lined by glandular epithelium. It is moderate in size, solid with cystic areas with hemorrhagic fluid inside. This is the gross appearance of the cut open Brenner's tumor. So mesonephroid tumors, clear cell tumors contain cells with abundant glycogen and are called hobnail cells. The nuclei of the cells protrude into the glandular lumen. It is highly aggressive tumor, occurs in 40 to 70 years of age. Now, sex-cord stromal ovarian neoplasm, these are the hormone-secreting tumors of the ovary. These tumors include fibromas, Sertoli lytic cell tumors, adrenoblastomas, or androblastomas. So fibroma, the origin are stromal cells of ovarian cortex, small sessile nodule, long pedicle, solid smooth surface tumor. Clinic on cut section, it is white in appearance. On microscopic examination, interlacing bundles of spindle-shaped cells, and complications are torsion and Meek syndrome. Androblastoma or Sertoli lytic cell tumor. This is testicular, it is divided into testicular adenoma, androgen secreting tumor. It is usually seen in women less than 30 years of age. There is gynandroblastoma, that is gynandroblastoma also. The clinical features can be amenorrhea, atrophy of the breast, enlargement of the clitoris, body hair growth, and deepening of the voice. So gross appearance of an ovarian fibroma, germ cell tumors. The origin may replicate stages resembling the early embryo. Can occur at any age. 12 to 15% of ovarian neoplasm, 60% of GCTs occur in children. Most common benign type is benign cystic teratoma. Dermoid cyst, the origin arises from single cell. Pathology is usually bilateral in 15 to 20% of cases. Torsion is most common, rupture is uncommon complication. On naked eye appearance, the size is usually less than 10 centimeters. The area of solid projection called rocky tensity protuberance is also seen. On sonography, there is fat, fluid, or hair fluid levels, accentuated lines and dots of floating hair seen. The signs like tip of the iceberg created by fat, hair, and tissues are seen. On microscopic examination, the tissue components can be ectodermal, mesodermal, or endodermal. The ectodermal are hair, skin, nails, nerve tissues. Mesodermal can be bone, cartilage, muscles. Endodermal can be thyroid, salivary gland, bronchus, or intestine. Stroma, ovary, and carcinoid. Now, stroma ovary is composed of thyroid tissue. Malignant changes are rare. These tumors may be hormonally active with secretion of serotonin, bradykinin, and other peptide hormone from the argentefin cells. Carcinoid syndrome, episodic facial flushing, abdominal pain, diarrhea, and bronchospasm are the clinical features that are present in carcinoid syndrome. Operative treatment of benign cystic teratoma, cystectomy with preservation of normal healthy ovarian tissue. Laparoscopic surgery may be done. Copious pelvic irrigation with normal saline is essential. This is the diagram of dermoid cyst. On clinical examination, the difference between the benign and malignant ovarian tumors are, it depends on the character. The benign is in younger and malignant is in older age group. Benign is usually unilateral, malignant is bilateral. Benign is mobile, malignant is fixed. Benign is cystic, malignant is solid in field. Benign has the smooth surface, malignant has the irregular surface. Benign has no ascites, and malignant cells ascites is usually present. And growth is very slow in benign and growth is rapid in malignant tumors. The nodules are usually absent, that is present in malignant ovarian tumors. The benign tumors on ultrasound shows unilateral, or multilocular cystic areas with regular thin wall septas and non-echogenic cavity, and Doppler show regular vascular branching. Malignant ovarian neoplasm on ultrasound shows bilateral thick wall, thick septa, echogenic areas, cavities with irregular heterogeneous parts. On it shows neovascularization and low RI and PI on Doppler. This is the diagram showing difference between benign and malignant ovarian tumors on ultrasound. As you can see on the diagram, the ovarian cyst that is benign is not having any septa, it is clear, and malignant ovarian tumor shows mass with thick septations inside. So the clinical features are the symptoms. It can be asymptomatic, detected accidentally. It shows heaviness in the lower abdomen, present with mass in lower abdomen, and there can be dull aching pain, cardiorespiratory and gastrointestinal upset like nausea and indigestion. The menstrual pattern can be unaffected except in hormone producing tumors. The signs are their presence of cachexic features and pitting edema over the legs. On abdominal examination, inspection shows bulging of the lower abdomen. The mass can be central, one side, or all over the abdomen. The visible veins are seen and the flanks are usually flat. On palpation shows cystic or dense cystic, freely mobile from side to side with restricted mobility in above downwards, smooth surface and non-tender. On percussion shows dull in the center, resonant in the flanks, and fluid thrill is usually present. Auscultation shows friction rub. On bimanual pelvic examination, the uterus is separated from the mass. The groove is present between the uterus and the mass. Movement of the mass per abdomen fails to move cervix. Lower pole of the cyst fell through the fornix. Absence of pulsation of uterine vessels through the fornix. Investigation is by ultrasound, tumor markers, straight X-ray abdomen, paracentesis, laparoscopy. So the differential diagnosis can be full bladder, pregnancy with fibroid, ascites, fibroid uterus, and cystic peritonitis. So the complications may be torsion, intracystic hemorrhage, infection, rupture, malignancy, pseudomyxoma peritonitis. So torsion can occur in axial rotation. The chances are 10 to 15%, usually occurs in moderate size. It is freely mobile. If it is freely mobile with a long pedicle, and it is very common in dermoid or serous cystadenoma, the causes can be trauma, violent physical movement, contractions of pregnant uterus, intestinal peristalsis. Hemodynamically, no. The symptoms can be acute pain with lump in lower abdomen, vomiting, fever, shock, tachycardia. On per abdomen examination shows tense, tender, cystic mass with restricted mobility. On per vaginal examination shows mass that is separate from the uterus. On differential diagnosis, there can be disturbed ectopic pregnancy, acute hydramnios, perforating molar pregnancy, torsion of subserous pedunculated fibroid. Treatment of pain can be relieved by analgesics. Laparotomy is done. Cystectomy or salpingo-oophorectomy can be done. Intracystic hemorrhage can occur in serous cyst adenoma, malignancy, venous congestion. There can be infection following torsion and rupture, pseudomyxoma peritoni. So, pseudomyxoma peritoni is usually associated with mucinous cyst adenoma of the ovary, mucosal appendix, and gallbladder. Intestinal malignancy is usually associated with it. Spontaneous perforation can occur. Recurrence is usually high. Prognosis is poor due to infection and intestinal obstruction. Treatment is usually hysterectomy with bilateral salpingo-oophorectomy with removal of mucin and peritoneal implants with appendicectomy. So ovarian cyst, if it is a cystic teratoma, laparoscopic surgeries can be done. Laparoscopic cystectomy can be done in simple cyst of 5 to 8 centimeter size, benign morphology with CA 125 level less than or equal to 35 IU per L. Follow up every 3 to 6 months or on combined oral contraceptive pills. If there is increase in size or if it is symptomatic, then do laparoscopic cystectomy, and all other cysts need laparoscopic cystectomy or diagnostic laparoscopy for further treatment. If the size of the cyst is 3 to 5 centimeter, if it is simple, benign, serum CA125 less than 35, Doppler RI more than 0.4, follow up every 6 weeks. If there increase in size of CA125 level is rising, then do laparotomy. If the size is more than 5 centimeter and morphology is suspicious and CA125 level is also more than 35, do laparotomy. Surgery in young women, ovarian cystectomy, oophorectomy. In Paris women, total abdominal hysterectomy with bilateral salpingo-oophorectomy. And in others, laparoscopic cystectomy or ovariotomy can be, or ultrasound guided aspiration of cyst can also be done. Now, the topic is borderline ovarian tumors. The characteristic features are they constitute 10 to 20% of all epithelial tumors of the ovary, intermediate in position between benign and malignant, formation of microscopic papillary projections, epithelial cell pleomorphism. There is a stratification of the epithelial cells of the papilla, presence of papillary projections on the external surface, detachment of cellular clusters from sites of origin, increased cellular mitotic activity, no invasion of ovarian stroma, presence of nuclear atypia of varying degrees, occurs in young age of around 30, occurs in younger age group, and prognosis is usually good. Borderline serous tumors, approximately 10% of all ovarian serous tumors fall into the category of a tumor of low malignant potential for borderline tumors, and 50% occur before the age of 40 years. Criteria for the diagnosis are epithelial hyperplasia in the form of pseudostratification, tufting, cribriform and micropapillary architecture, mild nuclear atypia and mild increased mitotic activity, detached cell clusters, absence of destructive stromal invasion. Borderline serous tumors may harbor foci of stromal microinvasion. Borderline mucinous tumors of the mucinous tumor of low malignant potential is often difficult to diagnose. Well-differentiated mucinous epithelium may be seen immediately adjacent to poorly differentiated focus. It is important to take multiple sections from many areas in the mucinous tumor to identify the most malignant alteration. Borderline endometrioid tumors. The endometrioid tumors of low malignant potential has a wide morphological spectrum. The tumors may resemble an endometrial polyp or complex endometrial hyperplasia with glandular crowding. Some borderline endometrial tumors have a prominent fibromatous component, adenofibroma. This is a diagram showing borderline ovarian tumors with Hodgkin cell presence lining the glands. Hodgkin cells lining the glands. They have bulbous hypochromatic nuclei that protrude into the gland lumen. Malignant tumors of the ovary. Ovarian malignancy constitute about 15 to 20% of all genital malignancies. Leading cause of death in women next to breast cancer in US. Approximately 1 in every 70 newborn female in the United States will live to develop ovarian cancer. It is more common among nulliparents. It is the fourth most common cause of cancer deaths in women. Ovarian cancer has the highest mortality of all gynecological cancers. The incidence is 6.1 per lakh. Mortality rate is 3.7 per lakh. The etiological factors are nulli gravida, incessant ovulation theory, use of coffee, tobacco, alcohol, and dietary fat, talc and asbestos exposure, breastfeeding, tubal ligation, hysterectomy have been associated with reduction in the risk. Genesis and ovarian malignancy, hereditary breast ovarian cancer syndrome, hereditary non-polyposis colorectal cancer, Lynch 2 syndrome, concept of fallopian tube origin. This is the schematic presentation of distal fallopian tube origin of ovarian carcinoma. The concept of LG-SOC and HG-SOC with STIC and P53 mutations are shown. Dualistic pattern of ovarian carcinogenesis, type 1 and type 2. Type 1 carcinogenesis, incorporation of Mullerian epithelial cells on the ovary, causing ovarian endometriosis, cortical inclusion cyst. Type of tumor is borderline tumors, low-grade serous ovarian cancers, clear cell cancers, mucinous carcinoma, stage at presentation usually early. Gene mutation is KRAS, BRAF, or PGEN, not P53. Clinical course is indolent. Type 2 carcinogenesis, incorporation of serous tubal intraepithelial carcinoma, STIC, with exfoliation of cells on the ovarian surface or in the peritoneal cavity. Type of tumor is high-grade serous ovarian carcinomas, usually undifferentiated, present during the advanced age. P53 mutation are present in 100% of cases. It is highly aggressive. Categories of cancer. Categories of ovarian cancer can be divided into epithelial that account for 80 to 85%, germ cell, sex cord stromal, metastatic disease, and hereditary. So epithelia can be high-grade serous, mucinous, endometrioid, low-grade serous, clear cell. Germ cell can be teratoma, dysgerminoma, endometrial, sinus tumor, embryonal carcinoma, choriocarcinoma, gonadoblastoma, mixed germ cell. Sex cord stromal can be granulosa cell, thecoma, fibroma, sertoli cell, gynandroblastoma. Metastatic disease can be GI tract, breast, endometrium, lymphoma. Hereditary can be hereditary breast and ovarian cancer syndrome, Lynch syndrome. Figo staging of the carcinoma ovary tube and peritoneum. So Figo staging of the carcinoma of the ovary tube and peritoneum in 2018 shows stage 1 tumor confined to the ovaries or fallopian tubes. Stage 1A is tumor limited to one ovary, capsule intact or fallopian tube. No tumor on ovarian or fallopian tube surface, no malignant cells in the ascites or peritoneal washings. 1B is tumor limited to both ovaries, capsule intact or fallopian tubes, no tumor on ovarian or fallopian tube surface, no malignant cells in the ascites or peritoneal washings. 1C is tumor limited to one or both ovaries or fallopian tubes with any of the following, like 1C1 is surgical skin, 1C2 is capsule ruptured before surgery or tumor on ovarian or fallopian tube surface, 1C3 is malignant cells in the ascites or peritoneal washings. Stage 2 is tumor involves one or both ovaries or fallopian tubes with pelvic extension below pelvic bridge or peritoneal cancer. Stage 2 is extension and implants on the uterus and fallopian tubes and ovaries. Stage 2B is extension to other pelvic intraperitoneal tissues. Stage 3 is tumor involves one or both ovaries or fallopian tubes or peritoneal cancer with cytologically or histologically confirmed spread to the peritoneum outside the pelvis and or metastasis to the retroperitoneal lymph nodes. Stage 3 1 Stage 3A1 is positive retroperitoneal lymph nodes only, cytologically or histologically proven, metastasis up to 10 mm in greatest dimension, and metastasis more than 10 mm in greatest dimension. And A2 is microscopic extrapelvic above the pelvic brim peritoneal involvement with or without positive retroperitoneal lymph nodes. 3B is macroscopic peritoneal metastasis beyond the pelvis up to 2 centimeter in greatest dimension with or without metastasis to the retroperitoneal lymph nodes. Stage 3C is macroscopic peritoneal metastasis beyond the pelvis more than 2 centimeters in greatest dimension with or without metastasis to the retroperitoneal lymph nodes. Includes extension of the tumor to capsule of liver and spleen without parenchymal involvement of either organ. Stage 4 is distant metastasis, including peritoneal metastasis. Stage 4A is pleural effusion with positive cytology. 4B is parenchymal metastasis and metastasis to extra abdominal organs, including inguinal lymph nodes and lymph nodes outside of abdominal cavity. Regional lymph nodes, annex regional lymph nodes cannot be assessed, and no regional lymph nodes metastasis, and one regional lymph node metastasis, MX is distant metastasis cannot be assessed, MO no distant metastasis, M1 is distant metastasis excluding peritoneal metastasis. Thank you.